Welcome back. Today we're going to be doing another episode in our Introduction to Jail Mental Health series. We'll be talking about what mental health treatment in jails looks like. We'll talk about how jail mental health differs from community mental health, how it would look in an ideal setting, and why it doesn't work like that most of the time. We'll also talk about the biggest issue with jail mental health care, which is the problem of care coordination. Okay, let's start with what treatment for mental health looks like in the community. For most diagnoses, the best course of treatment is 3 to 6 months of weekly therapy. Now, this isn't one size fits all, so you might need to go twice a week, or you might need to be in therapy for a year or more, depending on your specific circumstances in your situation and what your treatment goals are. If therapy alone isn't working, or if you're having severe symptoms like psychosis or mania, then you might need to supplement your therapy with medication. You're usually doing all of this voluntarily and at your own pace. This is all nice and tidy and organized, but this process doesn't work in jails for a bunch of reasons. First, you don't have a lot of therapists, and the therapists you have are preoccupied with a bunch of other mandatory tasks like mental health evaluations, suicide risk assessments, segregation assessments, sick call slips, urgent care issues, and so on. Meanwhile, about a third of your jail population probably need therapy. In a jail of 1,000 people, that's 300 patients. Even if you had one therapist for every 100 inmates in your jail, which I can already tell you, you don't, that would be 30 patients for each therapist on top of the 30 to 40 hours of work they already have to do each week. There is no possible way that everyone who needs therapy is going to get it every week. If you're lucky, you'll have enough therapists that each person can get a check-in with a therapist once a month. Now, there are exceptions to this, usually in very well-funded or grant-supported facilities, but for the vast majority of jails, this is how it works in practice. Second, even if you somehow had all the therapists you needed, they still need to work around the jail schedule. Jails are very busy places and everyone is competing for time and space. On any given day, you may have medical, mental health, corrections, an attorney, Department of Child Services, or whatever your state calls it, re-entry, and the courts all trying to see the same inmate. On top of that, jails work on rigid schedules and lock down several times per day to feed and count the inmates. In my jail, between 5 a.m. and 5 p.m., the jail's on lockdown for 6 hours, or 2 hours for each meal. So if your therapist wanted to see an inmate, they better hope that no one else already needed to see that inmate for something, that there are no attorneys or anyone else using up the confidential meeting space, that there are enough available officers to move the patient to you, and finally, that the patient is even willing to meet with you. A lot of people who need mental health services in jails will routinely refuse services even when they're offered. Between all of this, the planets would basically have to align in order for you to have a therapist meeting with a patient for 45 minutes every single week. And even if all of this somehow worked out, chances are very high that the patient is going to get out of jail within a week, so you'll probably never see them for a second session anyway. I have found that there is one very unique set of circumstances that can facilitate therapy in jails. If you have a patient who is sick enough to need to stay long-term on your mental health unit, and if they have serious charges which keep them from getting out of jail quickly, and if you have some mental health interns who don't really have more important things to do in the jail anyway, then this can be a situation in which some possibly productive therapy could occur. Hopefully, all this paints a good picture of why individual therapy doesn't happen much in jails. Now, I said individual therapy doesn't happen, but what about group therapy? This is actually more common and more feasible than individual therapy, but it's not without its issues and caveats. So issue number one, you're not going to do a traditional psychodynamic or process group in jails. This is because these groups really only work when the members can be vulnerable with one another and trusted not to divulge the things that are discussed in the group. Neither of those things are going to happen in any jail ever. So the groups you're going to actually see are going to stick with surface level content like anger management, emotion regulation skills, communication skills, parenting skills, etc. Issue number two, you really need all of the inmates who need the therapy and who are willing to participate to be housed in the same section of the jail. It's not feasible to run group in a different location every week, or for officers to pull 6 or 10 inmates from different sections just so that they can participate in an hour-long group. Issue number three, you need to run a group that's appropriate for everyone participating. Some of my favorite skills groups to run are focused on moral reasoning. I give the group a moral dilemma and have them weigh the pros and cons of various solutions. It's both fun and thought-provoking at the same time. But I can't run this group in a jail because the people who are sick enough to need to be in the mental health unit are almost all too sick to have a serious conversation about something like this. Jail mental health units across the country all have this sort of catch-22 situation, and that is, people come to the mental health unit because they are debilitated and can't function, or because they're suicidal. As soon as they're stabilized and are in the proper frame of mind to participate in a mental health group, we have to move them to general population because we have other people who are sick and need their bed in the mental health unit. In other words, if someone is healthy enough to participate in group, then they're not going to be housed in the section where the groups are run. The reason this happens, as we have discussed, is that jails have become de facto mental health hospitals. Even in the past 10 years, it's gotten worse. And a quick anecdote here. When I started working in corrections, we had about 8 people who should have been in a psychiatric hospital rather than a jail. Now I'd say we have about 40. That's a 400% increase in only 10 years. Now, some really progressive jails, and this is more common in prison, but some jails have what we call step-down units. These are for people who are mentally ill but recently stabilized and not yet ready to return to general population. If your jail has a unit like this, then this is where most of the quality group therapy is going to take place. So, group therapy is uncommon, but it does exist in some jails, but individual therapy basically doesn't happen anywhere. So, why do we need therapists in jails then? I touched on this briefly before, but the short answer is that master's level therapists in jails are primarily there to do assessment, diagnosis, and to act as sort of gatekeepers for higher levels of service and special interventions. We might go into a deeper dive on that in the future, but I wanted to stay focused on treatment for this one. The last type of non-medication treatment for mental health in jails is what we call behavior modification. If you've ever heard the term conditioning, this is what we're talking about. Basically, behavior modification is when you set up rules or consequences for a patient in order to encourage certain behaviors or discourage others. For example, you might tell an inmate that if he keeps his cell clean and participates in group, then he can come out of his cell for an hour and watch TV. You're not forcing him to do it, but if he doesn't do it, he doesn't get to come out for TV later. This is a very basic example of behavior modification. I mention it because behavior modification can be a useful tool to shape patient behavior without coercing them. If you set up a basic behavior mod system in your mental health unit, for example, you have to keep your cell clean to earn extra TV time, or you have to take your medication all week to participate in movie night on Fridays, then you're more likely to see consistent positive behavior from your patients. Behavior mod isn't going to help you as much for patients with psychosis or mania, but it's still a good tool for other patients. Now, if you've heard me talk about medications in other videos, you probably know that I think they should be viewed with skepticism and caution in general. That said, I won't deny that they can be helpful in certain cases and are basically mandatory in others. But regardless of what I think, psychotropic medications are the backbone of mental health treatment in jails. And this is primarily because they can be administered quickly. It takes 45 to 60 minutes for one therapy session, but a single medical assistant can give antidepressants to 10 people in less than 2 minutes. Most jails will schedule med pass for 2 or 3 times a day and can give urgent medications on an as-needed basis. There's not a lot for me to say here. Patients complaining of depression are given antidepressants. Patients complaining of anxiety get low-grade anxiolytics. In my jail, these two groups make up about 80% of the mental health caseload. The other 20% are patients who take antipsychotics and/or mood stabilizers. Now, the 80% on things like fluoxetine or run-of-the-mill antidepressant usually take their medications without issue. The other 20% who need antipsychotics or mood stabilizers tend not to like to take their medication. This is where jail mental health gets interesting. Jails are not hospitals, so they don't qualify for all of the legal protections that a hospital might have. At the same time, jails have some patients, especially mental health patients, who are more gravely disabled and/or dangerous than you would find at a hospital. So we have all the liabilities of a hospital without all the protections of a hospital. Then you have another wrinkle, which is that pre-adjudicated inmates, in other words, people who have not necessarily done anything wrong, are in a precarious legal situation. They have to be detained, but other than that, the courts try to afford them as many civil rights as they can. This all comes to a head when a jail clinician, such as myself, believes that a patient is disabled or dangerous because of his mental illness and that the patient requires medication to treat his condition. Now, here's the part of the video where you can listen to what I'm saying, but you really need to check your state statute because there may be some subtle differences between the way I do things and the way your state expects you to do them. And before we get into this, I wanted to note that involuntary medication is something clinicians try to avoid whenever possible because it carries serious ethical and safety risks. So, as I've said before, simply having delusions or hallucinations is not enough justification to involuntarily medicate someone. The patient has to pose an imminent risk of harm to himself or others or be gravely disabled. The definition of grave disability is difficult to pin down, and we could probably do a whole video on edge cases that could go either way. Is this person disabled or not? For our purposes today, we'll just define a person as gravely disabled if, due to a mental illness, the person cannot feed, clothe, or bathe themselves, or is unable to communicate in a meaningful way. So, if the treatment team determines that a patient is at imminent risk due to one of these criteria, they can administer a one-time dose of short-acting antipsychotics or sedatives. The usual go-to meds in this situation are haloperidol and lorazepam, with or without hydroxyzine if the prescriber is worried about side effects of the medication. This isn't set in stone though, so your jail might use different meds. Now, these situations count as medical emergencies, so we don't need permission from the patient or from the court to administer them. However, if you have a severely mentally ill individual who doesn't want to take medications, you might find that your emergency injection of psych meds fixed the problem temporarily, but then the next day the patient is once again having a psychiatric emergency. Then you have to do another involuntary injection again. And every time you give medication to a patient involuntarily, there's a chance that someone gets hurt. It could be the patient, an officer, a member of the medical staff. So the best thing to do if you foresee this being a problem is to give the patient a long-acting antipsychotic injection. These injections can be given once and slowly release medication for the next 30 to 60 days. It's obviously much safer to give this injection once rather than having to do it every day for a month. I can tell you this from experience because we had a patient one time who was allergic to all of the long-acting antipsychotics, so we had to give a short-acting injection every day for like 2 or 3 weeks. Anyway, since long-acting medications continue to affect the patient even after they've been restored to a functional state, and because once you inject that medication there's no way to get it back out again, you can't just give a long-acting antipsychotic injection in a temporary emergency. If you want to give a long-acting antipsychotic to a patient, you have to do one of two things. The first is the easy way. You write a petition to whatever criminal court has jurisdiction over the patient's case, explain the situation, and ask the court for permission to medicate the patient involuntarily. The court will do one of three things in response. The court could disapprove, at which point they've kind of taken responsibility for the patient decompensating. The court could approve, at which point you're good to go. Or the court could hold a hearing to figure out what to do. I have testified at many of these hearings. I basically make my case as to why I think the patient needs to have medication, and the patient and his attorney have a chance to argue why the medication should not be given. This almost always benefits me because the patient usually either refuses to come to court or shows up and threatens people or says something psychotic, which helps to prove my point. The second way to get approval for a long-acting medication is the hard way. I'm not going to get into all the nitty-gritty details about this, but there was a Supreme Court case, Washington v. Harper, which established an alternative method for green-lighting long-acting antipsychotics that does not require you to go to court. You can establish what I call a Harper Committee. Basically, you have to get a panel of independent medical doctors who do not work for your facility to hear testimony from the treatment team and the patient, and they make an independent judgment about whether or not the patient needs the medication. Again, keep in mind that different states have their own interpretations and guidelines related to the Harper decision. So, this makes sense on paper, but is practically impossible in almost every circumstance. I've talked before about how scheduling things in the jail is hard. In order to do this, you would need to somehow get 3 doctors who don't work in your facility to take the time out of their day to hear testimony from both the patient and other members of the treatment team, and the independent doctors can't be paid for their time, otherwise it creates a conflict of interest, unless the state were to pay for it, and we all know they're not doing that. And consider, while you're trying to orchestrate all this, the patient is sitting in their cell and getting worse every day. In short, this method is so cumbersome that basically no one does this. I've literally never heard of anyone doing this outside of the Supreme Court case in which the rule was established. For most jails, this is just not feasible, which is why you see everyone using option 1, which is to petition the court. So that pretty much wraps up what treatment in jails looks like. I didn't talk about substance abuse treatment in jails because it's a more complicated topic and most jails don't really do it anyway. If people are interested, I can do a video explaining this in more detail. Lastly, I wanted to talk about care coordination and why it's so important. This is the single biggest reason jails function as revolving doors for people with serious mental illness. When mentally ill people leave jail, they have a very high probability of coming back, usually within weeks or even days. I've seen mentally ill people get released from jail and get arrested within an hour. They basically walk out the front door, go down the street, trespass or steal from the gas station, and then get brought right back to the jail. In a society with a functional mental health system, this would not happen. But hey, this is America, and most voters don't prioritize mental health care. That's just how it is. So, why do mentally ill people get rearrested so frequently after leaving jail? It's basically because they were already in a precarious situation prior to their arrest, and they're thrust right back into that situation when they leave. They're often homeless, broke, have no friends, and no transportation. Realistically, what did you expect them to do? Can't they go to a shelter? Nope. Shelters almost always refuse to admit people with mental health problems. And I get it. I call a shelter and say, hey, we've got Bob here with schizophrenia who was in jail for stealing and assaulting his mom. He won't shower voluntarily and regularly makes racist and sexualized comments. Can I send him to you guys on the bus? Shelters aren't prepared to deal with someone like this. Can't they go to a hospital? And listen, I'm going to let you in on a little secret. Hospitals are not interested in taking homeless psychotic patients. This isn't because hospitals are cruel, it's because the incentives are structured in a way that makes these patients financially and operationally risky. Let's talk about why. First, if it's not a behavioral hospital, they can't really do anything anyway. All they would be doing is sedating the patient and keeping him in a room until a behavioral hospital could take him. Second, even the behavioral hospitals don't want these patients because they can't bill for them. Medicaid, which is the primary payer for most psych patients, has a lifetime cap of 190 days for inpatient psychiatric care. After that, hospitals don't get paid to care for psych patients. Even when Medicaid does pay for care, the reimbursement rates are low relative to private health insurance. So if you're a hospital, you really want to avoid these patients. They're behavior management issues, so they're going to be difficult to deal with, and you might not get paid for their care. Because of this, most hospitals, even behavioral health hospitals, have adopted this posture where they will not take psych patients unless they absolutely have to. Hospitals are subject to legislation called EMTALA, or the Emergency Medical Treatment and Active Labor Act. In a nutshell, this law requires hospitals to admit patients in an emergency regardless of the patient's ability to pay for care. This is why hospitals routinely refuse to admit psych patients unless the patient says he's suicidal. And this has trained a whole subset of people who are homeless and mentally ill whenever they're hungry or cold to show up at the hospital and say they're suicidal. And if you're thinking that maybe the patient should go to a state psychiatric hospital, your intuition is right, but the state psychiatric hospital system is broken nationwide, and this is a whole rabbit hole of its own. Maybe we'll do another video on that at some point. So for now, just assume that the state hospital is off the table. So anyway, you have a mental health patient who is psychotic at the time of discharge. You have to hope they have a friend or family member that you can call to pick them up. Otherwise, you're going to have to do an emergency detention order, or whatever your state calls an emergency mental health commitment, to the local hospital. The local hospital may refuse to admit the patient, because even with an emergency order, the hospital reserves the right to make decisions about who they will and will not admit. From my perspective, as the mental health director of the jail, if I get a patient to the hospital on an emergency detention order, I have officially passed the torch. If the hospital doesn't admit the patient and something bad happens, that's kind of on them. My jail no longer has clinical authority over that patient's care once they walk out of the building. So moving on, once the patient is out of the building, whether that be living with family, in a hospital, or wherever, this is when the biggest gap in treatment usually happens. The patient, who may have been stabilized on medication while in the jail, now has limited supervision in the community and very likely lacks the wherewithal or the means to get more medication. They stop taking their meds and once again become psychotic or manic, and this inevitably leads to them getting rearrested, and then the whole cycle starts all over again. Ideally, the jail itself would give patients a 7 or 30-day supply of medications to tide them over until they can get in to see a prescriber in the community, but I don't know if any jails do this, simply because of the cost. So, if at all possible, you want to identify patients who are at risk for cycling like this early in their incarceration and start planning for their discharge in advance. Like I've said before, this doesn't always work because you can't control when a judge decides to release someone or when someone bails them out. But if you can, it's a good idea to establish a working relationship with your local community mental health center. If they're willing to work with you, they can come into the jail either in person or remotely to meet with patients to get them scheduled for services when they leave the jail. Some community mental health centers even have mobile crisis teams, which might be able to meet the patient in the lobby when they're released and can transport them to treatment if needed. Or even have a provider meet them in the field to get them started on their psych meds again. However, not all mental health facilities are willing or able to do this, so you might have to settle for just having your prescribers call a 30-day prescription into the pharmacy for the patient and cross your fingers that they somehow get over there to pick up their meds. Now, there are other methods of ensuring coordination of care. For example, mental health courts offer oversight while connecting patients to a variety of mental health services. There are also outpatient civil commitments, otherwise known as assisted outpatient treatment, which sort of do the same thing, but have a little bit more in terms of teeth if the patient chooses not to participate in treatment. I'll do another video on mental health courts and AOT another time. So, this has been a look at how treatment works in jails. Let me know if you have any questions or if there are any other topics you'd like to know more about. That's all the time we have for our session today. I'll see you next week.